This is a show about the diversity of academic and experiential backgrounds of people working in patient safety. My name is Ivan. I am a lab rat turned infection preventionist. While struggling to find work, I reached out to a friend for support. Our chat turned into a LinkedIn post that showed me that many people in our field were in the same situation. The purpose of the Safety Spectrum podcast is to celebrate credential, educational, and experiential diversity, to share the values and success stories of non-traditional staff in quality patient safety and infection prevention, to advocate for competency-based versus credential-limited hiring, and to increase awareness of the importance of the infection preventionist and other roles in the healthcare safety sector.
Ashley Reyes is one of those rare people whose very first role out of school was truly her dream job. She has a Master of Public Health from Georgia Southern University, and she stepped straight into infection prevention and control onto my team at UNC Pardee Health, where her talent and drive were obvious from day one. In this episode, I will be talking to one of the bright emerging voices in infection prevention and control. Welcome to the Safety Spectrum.
I am joined today by my good friend, Ashley Reyes. Welcome, Ashley. Ashley is the first infection preventionist that I ever hired. So
this is true.
Yes, we worked together for close to a year, and I think we had a wonderful time. What say you?
We had a great time. Some work, some goofing off. It was all good.
It was great. I thought it was great. So, Ashley, tell us your, short summary of where you are and what you're doing and all of that good stuff.
Sure. Yeah, so I'm Ashley. I'm an infection preventionist at a small community hospital in Western North Carolina. Ivan mentored me, made me who I am today. I wouldn't have found infection prevention if it hadn't been for you, Ivan, so that's pretty cool. That's a good accomplishment, I think.
Yes. I've done well in life. I'm done. I can retire now.
So I've been at this hospital for a little over 3 years now. My background is mostly in public health and epidemiology. I went to grad school in Atlanta at Georgia State and finished my MPH in environmental epidemiology. I was the classic MPH, didn't know what they wanted to do, had worked in a hospital before. I worked as a nursing assistant in a hospital in Atlanta and wasn't sure how I wanted to proceed. Saw a job posting, interviewed with Ivan, and then worked together for about a year before he left me. But yeah, I've been here ever since. So kind of the classic MPH who wasn't sure what they wanted to pursue and found infection prevention.
Wonderful. So a fun story for me to tell is that when Ashley applied for the position, I think I caught her on the phone once when she was coming off shift, and you had been working the night shift or something, and we'd been trying to connect, and my emails were going to an old email account or something, and somehow I accidentally dialed your number on my desk phone. I was trying to call someone else. I accidentally dialed your number. I hung up, and then you called me, and we had a conversation about your second interview.
Yes. I was so stressed waiting for a call. I saw an 828 and I was like, I have to call back. I have to see. I need a job. It's so funny.
Yes, that was great. So your academic background, you mentioned environmental public health. Was that your master's or your bachelor's?
Master's.
Okay.
I'd say I've always had a larger interest in environmental health. I took quite a few environmental health courses in undergrad, but when I went to grad school, I knew that I wanted my focus to be in environmental epi. So while I was there, a lot of my courses were just more focused in environmental assessments, exposure control, things of that sort. I got to do a really fun project looking at environmental assessments in communities that were near rock quarries. So we got to take some environmental samples looking at black carbon and other levels in the area. So that was one really fun assessment that I enjoyed. And then while I was in grad school full-time, for some reason I thought I wasn't busy enough. So that's when I started working as a nursing assistant. And I worked night shift, as Ivan said. And that was really hard. I'm not really sure how I made it out alive doing that, because it was during COVID. It was full-time night shift, and I was still figuring out what I wanted to do. I would sometimes work a night shift. I would go park in the parking garage at Georgia State where I went to school. I would take a little nap, and then I'd wake up and go to class. So I'm not sure why I chose to do that, but it was a great work experience because that gave me an introduction into working in healthcare. And I think if I hadn't had that role, I probably wouldn't have found infection prevention, honestly.
Okay. Your LinkedIn profile talked about an internship at the CDC. Tell us about that.
Yeah, true. That was also during COVID, so mostly remote, but it was very helpful. So to finish my bachelor's degree, we also had to complete an internship. And so I got to intern with CDC's Epidemic Intelligence Service. And being that it was during the beginning of COVID, it was very busy. It was very task-oriented. They needed a lot of people to help with reviewing abstracts and reviewing job applications and things like that for their EIS officers. So I got to work with some awesome folks at CDC and kind of get some insight into how EIS was responding during COVID, and then also to other epidemics that were occurring across the country. So that was a really cool experience to make some connections and kind of see what working in epidemiology would be like.
What is, from my own education, the difference between environmental epidemiology and like healthcare epidemiology?
Environmental epidemiology focuses more on what you're exposed to in your environment, whether that's living, say I live in a house, like I said, that's near a quarry. I'm more likely to be exposed to certain toxins and have like a higher predisposition for asthma and other like chronic illnesses. And then just being outside, work in general. I did one interesting project in undergrad looking at sun exposure in outdoor workers. So it's not strictly just looking at acute or chronic disease. It's kind of a more broad focus on how is the environment that I'm in, me being at work right now or me being at home, how is that environment potentially impacting my health?
Okay.
If that makes sense.
Yes, absolutely. Wonderful. And so you you worked as a patient care tech, and what unit did you work on? Any fun stories from there?
So many. There are so many. Healthcare is such an interesting place. So I worked on an ICU. Mainly we were a trauma ICU unit in Atlanta at Atlanta Medical Center, which has actually since closed. Not my fault, but it closed. And we had a few different sections of the ICU. It was mainly just a medical ICU, but we had a trauma section, CVICU, CICU. And so while I worked there, all of the patient care techs or CNAs, we covered all of the units. I want to say we had 20 to 30 beds. I can't quite remember. But we saw a lot of motor vehicle accidents, lots of different COVID cases and other complex cases that were happening. And that was a really good experience for me to to realize I did not want to work in patient care, that was not for me. It was helpful to see all the different aspects, and I think having that experience now, I look back and that's really helpful in my approach as an infection preventionist. But I knew after that, the burnout was so quick. I was like, okay, this is not for me. I have to look at something else. But it was really cool. I got to help with some central line insertions, and I remember on my last day, actually, this is a funny story. I had never gotten COVID through the pandemic, never got COVID, was totally fine, took care of lots of COVID patients. And on my last shift, it was like the last hour of my shift, I noticed like one of the patients is falling out of bed, and of course hospitals don't want falls. So I run into the room. He's on isolation, but I don't have time, and I don't want him to fall out of the bed. So I run into the room, and I go, and I'm trying to help him, sit him up, get him back nice and comfortable, and he just coughs directly in my face. This patient also had COVID at the time. I don't think I mentioned that. Coughed directly in my face. Had a bunch of phlegm and all the fun stuff all over me. So it was a really good ending to my time there. But I still didn't get COVID from that. So.
Oh, wow. All right. Excellent.
No PPE, nothing, but.
Yes. We need to find a way to spin that to make that a cautionary tale. Yes, we don't want healthcare workers listening to that and going, you didn't get it, so, All right.
I'll leave that part out.
So, what advice would you give an aspiring infection preventionist? So the way I've presented this question to other guests is, what would you say or do for you if you could go back in time to help a younger you or the next generations of IP? How do we make things easier for those coming up behind us?
That's a good question. I think a large issue with some understaffing and not having a lot of infection preventionists is a lot of people don't even know the profession exists. I'm one of those, and I've met so many IPs that just incidentally found infection prevention. So I think that there needs to be a larger, I guess, recruitment effort, maybe informational effort to know about the work that we do. But for me personally, I think I would have benefited from just talking to people about the jobs you can have in healthcare. Just asking about all of the different departments, maybe even when I worked at Atlanta Medical Center, just learning about the ins and outs, kind of what the day-to-day looks like for each of those roles. I think that would have been really helpful for me. I probably could have jumped into patient care earlier. I don't know if that would have been an option for me. But I think just being more curious about the jobs that are out there, being open to applying for anything, any job, any role that my qualifications would meet, that would be helpful.
Okay. I speak for myself and many other infection preventionists. When we see the job description, I don't know that we always know what we're looking at.
That's true.
Like, this looks interesting, but I have no idea what it is about. Yeah. And yes, there are other people that I've talked to who, when we applied for the job. So, for example, my first interview into infection prevention, I was told about the job by one of my supervisors, and I called the infection preventionist and I said, hey, I looked at your job description and I don't know what any of these words mean.
Yeah, classic.
So, yeah, is it possible for us to just have this informal meeting where I can get a better sense of what the job entails? And so I met with her and we had that conversation, and I kid you not, about a week after that, she sent me an email and she said, your first interview went very well. I would like you to come in for a second interview.
That was an interview? I think you and I had the exact same thing. I definitely applied for the job like just seeing that I met the qualifications to apply.
Uh-huh.
And then I remember you called me and explained everything and even gave me resources and were like, hey, even if you don't end up here, here's APIC. Here's what you need to look at if you're interested in the field. So yeah, I think we had the exact same thing where I wasn't really sure what I was getting into.
Yeah. So in addition to, the younger generation asking questions, I think we as current infection preventionists almost have a responsibility to describe the work better, I think,
Right.
especially to people who are not directly in patient care. So,
I agree.
okay.
It can be
Yeah.
hard to explain, but I think
Yes.
talking about what the day-to-day looks like is a
Mhm.
really good place to start.
Yes. And if there is any benefit to the pandemic, it put our work front and center.
Right.
And so I have often used the pandemic as an example to describe to people what my work is in infection prevention. So yes, unfortunate circumstance that it has kind of given us an example that everyone
Right.
is familiar with. So what do you think, and in your experience, what makes a good and or successful infection prevention and control program?
I think from my experience, there's a few aspects that have to be met. So the first I think of is having a well-rounded group. So
Okay.
my work and any work as an infection preventionist is not going to be successful if you don't have everyone at the table and you don't have everyone bought into the program, right? So
Hmm.
like if I don't have nursing in my corner, if I don't have physicians and surgeons in my corner, then all of the policies and the processes that I'm trying to roll out, they're not going to go anywhere. They're just going to stay in infection prevention, if that makes
Hmm.
sense.
Yeah.
If I don't have, bedside team members at the table when we're having discussions about changing a certain process, we're not going to get buy-in from those groups. And I think I have personally seen that when individuals are left out of conversations, new ideas just don't pick up as quickly as they should. So I've made a really big effort to make sure that, when we're having conversations about changes to the program or changes to processes for inpatient nursing, everyone that needs to be there is present. And that's helpful. I do also think that buy-in from C-suite and higher leadership is very key. Sometimes I can work with nursing leaders and leaders throughout the organization, but if I don't have that buy-in from the highest level, sometimes things just don't move as quickly as they should. So having the CNO, CMO, having all those folks with you and on the same page, I've found is really helpful in getting traction.
Okay. Um, Going back to your first point, collaboration, what what are some ways that we can foster collaboration? Generally speaking, we tend to be the hand washing police, or I talk about this a lot, and probably happened when I was rounding with you once, where we walk up to a unit and someone yells, "Ivan is here, everybody wash your hands," or something like that. So how do we foster collaboration if and especially when IP is almost seen as an enemy or an adversary to clinical processes?
Yeah, I think that's a good point. I have personally always tried to just be approachable. I think from day one when I started, you and I had the conversation of, you're going to walk around and people are going to quickly try to clean their hands and act all, strict and try to be better because you're around, if that makes sense. And so I have personally always tried to have a good approach. If I see something that looks off, having the conversation of saying, well, I'm interested to know, why you might be missing hand hygiene. Let's have a conversation about it. I think being an approachable IP makes folks more likely to buy in and to be inquisitive and ask questions when they have issues. I think you can also incentivize people, especially inpatient nursing staff. That's one I definitely try to do. But I think when it comes to like changing human behaviors, you have to give the reason why. You and I have talked about this many times, but giving the explanation of saying, here's our current state, here's why it could be dangerous for you, for patients, for other team members, here's why we need to make that change. I think if you go back to logic and safety, especially with people who are taking care of patients, they're likely to make a change, or to at least be open to having a conversation with you.
Okay.
But it's hard. I mean, I worked in a unit in bedside care, and it's hard. When someone who isn't doing your job comes up to you and says, this that you're doing is bad, you need to change it, can sometimes feel like a personal attack.
Yes.
So it's hard as an IP to have that approach when you're trying to make big changes.
Yeah. And any pointers on getting C-suite on board?
That one's so hard.
I think you've had a lot more success with that than I did.
Yeah.
So, yeah. What have you done differently?
I think staffing has changed. So that has been different. And I've had established relationships with C-suite team members who've moved up the ladder.
Okay.
But I think having those one-on-one, those personal meetings of saying, here's what I'm trying to accomplish and here's how you can contribute is really helpful. I found that a lot of C-suite staff are very task focused. I have to be at this meeting. I have to get this task done by Friday, things of that sort. So if I already in my head have how they can help me accomplish this task and I convey that to them, that's usually helpful. So I find with our CMO saying, an email or a notification about this change coming from you would be really helpful. They're more likely to get on board.
Okay. All right.
And I think you eventually figure out how everyone works, right? Like I know our CMO, if I lay out the task, it's going to get done. But if I have a one-on-one meeting with our CNO to have that conversation face to face, we're more likely to come up with solutions together. So it honestly takes time. And I think I'm finally, after 3 years, understanding how to communicate with each of those groups. Because at first it was tough. And Ivan, you and I had some really tough run-ins at some points along our year together. Yes. So it's a learning process and everyone works differently.
Good. So just kind of learning how your individual C-suite people work best and adapting to that.
Exactly.
Okay. Excellent. So I know from working with you and from reading that there is, you're very conscientious about your work-life balance, and so how have you managed to create better boundaries for yourself? I know when I worked with you and even before you joined the team, I spent many nights at home on the computer, sending emails at midnight and doing surveillance at 1 a.m. How have you avoided those terrible lessons that I hope I taught you to avoid?
Yeah,
maybe I had nothing to do with it.
I feel like I would see that you sent an email and I would be like, Ivan, why are you working? I think when I first started, when you're a new IP, I think you even told me in the beginning, it's like drinking from a fire hose. It's a lot of information all at once, and it can be really overwhelming. I always felt like there's no way I'm going to know how to be an IP ever. there's too much information. I'm never going to figure it out, which isn't the case. But in my first few months, I did take work home with me a lot. I was trying to keep learning after work and make sure that I had all my tasks written down. I was doing all of my training. I had everything good. And then after a few months of kind of getting more comfortable, when I would have maybe uncomfortable exchanges with team members at work, I would take those emotions home with me, and it was very toxic. For a little while, I didn't want to come to work. I had this really negative connotation of going to work, and I was fearing those uncomfortable interactions that are going to happen in infection prevention. It's just inevitable. And so I made it a point to say, you know what, I have to leave work at work. I have to leave my emotions at work. Once I get into the car, I'm not thinking about work anymore. I'm not talking about it, and I'm in a new mindset. That can be really hard to do, especially as a sole IP. You did it for a long time. It's really difficult, and I can't imagine during COVID that it was probably impossible to not take work home with you. But I tried to just make it a point to leave work here. You know, me sending emails at midnight, it's not going to make a difference in my next day. There's still always going to be more work to be done. My tasks are still always going to be there. Taking my personal time to do work when I'm not getting paid for it and not, you know, I'm in my safe space, my home, is not beneficial for me, and it's not beneficial for anyone that's at work. You know, sending that email, doing those tasks at home, it's not going to change anything in the grand scheme of things. The work is still always going to be there. That's what I tell people too. The work is still going to be there the next day. If I'm not here, someone else is going to do the work. It's going to get done. So it's not worth your mental health. I think also working in a hospital, burnout is such a big issue, and I know it is in infection prevention as well. And I think that a lot of IPs tend to work too hard sometimes. I think we're not superhumans, you know, and like
we
I
wish
said,
we were.
and we sure do. We always do. But I think for me as a sole IP, if I want to stay in this job, I have to have a clear divide between work and home.
Is there anything like any kind of practical tips that you can give for that? So, for example, I have a friend who said, you know, when he was commuting, there was this billboard that for him was a marker. That when he passed that billboard, he kind of shed his work persona, if you will. Is there anything like that you have done? Anything that you think might be helpful? Because I still struggle with that.
It's hard. And I think the last thing you want to do is keep it in, right? Mine is kind of corny. And you might make fun of me for this. It's okay. I call my mom after work every day, and we hash out our day, and we'll talk about the good things, the bad things. And then once I hang up that phone call, work is done. I'm not talking about work anymore. I tend to overthink, and my task list becomes so long, and I'm looking at it because it's right in front of me. But my task list becomes so long that I get overwhelmed and feel like I'm never going to get anything done. So if at the end of the day, I still feel like there's a lot to do, I'll make an immediate list for the next day of, okay, here are my top priorities that I need to get done first thing in the morning, so I can feel accomplished when I get into the afternoon. And I found that that's been really helpful for me. I use my whiteboard probably far too often, but having things written out or putting a placeholder on my calendar to get certain things done has been really helpful for me.
So just to summarize your response, you have this person that you talk to every day, and you deal with all of the work stuff, and you leave it there.
Yeah.
That's wonderful. That is absolutely wonderful. So
It
yeah,
wasn't intentional either. I just call my mom
you just
and
say.
I just call her and we talk. And
That's good.
yeah, and you know, sometimes at home, of course, I'll talk to my fiance about work and we'll talk about the struggles of the day.
Uh-huh.
But I think we're really good at saying we're home. This is our time at home.
Yes,
Work
yes,
is over. So
yes, absolutely. We have 10 minutes to vent about work, and then we're done.
exactly.
Yeah,
Yes,
yeah,
exactly.
wonderful.
Or like what the best part of the day, your worst part of your day. I like
Uh-huh.
to do that one a lot too.
Yes, yes. Yeah, I did that for a while. I think I stopped when the worst part of the day became someone's name. And then I stopped doing that exercise. So
Yeah,
uh,
it's
that's not
hard.
good. That's not good.
It's still venting. You have to get it out.
Yes, it is. Yes, it is. So do you have an IP problem that keeps you up at night?
I think the what keeps me up at night is some type of GI infection cluster outbreak on an open unit. I think open units are a lot more complex for infection prevention because there's certain things we can't control. Like hand hygiene is more complicated. You know, there's a lot of shared spaces. So those types of infections where we're requiring hand washing, bleach products, that can get really complicated on an open unit. So that would
So
probably be
open
mine.
open units, you're talking about like rehab settings and things like that.
Yep.
Therapy. Okay, all right, yeah, yeah.
Yep.
No, that would be horrible because isolation doesn't really work in those kinds of settings.
It doesn't. And those
Yeah.
patients need to be out. They need to
Uh-huh.
be in
Yeah.
public areas and not in enclosed spaces. So, um, a lot of infection prevention practices become really, really complex.
Hmm. Have
And even
you,
thinking, sorry,
go
I
ahead.
was going to say, even thinking about like an inpatient psych unit, there are a lot of different restrictions that patients on those units have, and you have to be very careful. So implementing different precautions because of infection clusters, it's more complex and
Yeah.
it's difficult to track and to monitor.
Okay. Since you have experienced that, how, what helped? What worked well in those situations when you have experienced them? Hopefully it was just once.
Yeah,
Never mind.
there there've been a few. I think communication is the biggest thing. Notification of even one diagnosed case is key. Because when we have one case, especially on an open unit, we have to automatically assume that any patients with symptoms are also going to be positive, and you have to
Mhm.
implement measures as soon as possible, especially for illnesses like, you know, norovirus. If you're not automatically going to hand washing, using bleach products, it's going to spread quickly, especially on
Yes.
those open units. Um, so I think immediate notification of a case is key. You know, defining the symptoms that you would, how do I want to say that?
Case definition.
Yeah, lining out the symptoms that meet your case definition, really important, and just having a plan for moving forward. So, how is
Hmm.
the team working on that unit? How are they going to respond? What's going to change in their day to day? And establishing that early on when you have one or two cases is far easier than if you have five, six, seven.
Yeah. Okay. That's uh that's good. That's good. Yes, those are difficult experiences. And thinking about whether it is a geriatric rehab setting or a psych setting, especially, or even if you are in a pediatric setting, the difficulty there is also the patient's um, understanding of this unfolding situation
Right.
sometimes can be difficult. I cannot imagine having something like that in a memory care unit. Yeah, because with certain things, you definitely need patient buy-in.
Hmm.
compliance with the measures that are in place. So yes, that can go bad very, 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 very quickly.
Yeah.
Is there anything else you want to talk about that you think your peers at Georgia State University would want to hear from their illustrious alum?
I don't even think they know I exist.
Well, they will. You're going to be famous. You have a paper published.
I'm
Uh,
so excited about that paper
ooh,
too.
we should
That
talk about that.
I'm so excited. I can't wait to see it and put it on the fridge.
I have a difficult question for you as we close up. Are
Okay.
you ready? So, you talked about your COVID exposure last day as a CNA. With everything that you know now, one of the things that we tell staff is it's better, we prefer for them to be protected and to wear their PPE. And so I know that that situation is very difficult for bedside caretakers to manage. They do not want a patient to fall. No one wants a patient to
Right.
fall because that could be horrible. So, um, how would you fix that? Is there a fix for it, or is it just, things like that are going to happen?
Yeah, I think my issue in that case was I hadn't thought about just being, let me think if I want to say that. I hadn't thought about taking precautions because of what was happening on the unit. I think as an
Hmm.
IP now, I would have looked at the unit and said, okay, we've got 10 patients with COVID. It's probably a good idea for me to keep a surgical mask on most of the
Uh-huh.
time, regardless of what patients I'm taking care of or if I'm in a main hallway. And then also accessibility.
Hmm.
Our PPE was in carts where you had to open up the drawer, pull all the PPE out, so there wasn't time for me to quickly access it.
Hmm.
I think now we have the really convenient PPE caddies that go over doors, and masks are usually right there. I can just grab one and put one on. But I didn't have that IP focus in the back of my head, and so I certainly would approach it differently now, and making sure the PPE is accessible, and then also knowing what's circulating in the unit, I think would have made a difference.
Excellent. Yes. PPE accessibility will always be a big deal.
It's key. If it's not
Yes,
there, you're not going to use it.
absolutely. Well, Ashley, thank you very much for your time. We appreciate you on the program and hope to see more of you at some point.
Same here. Thanks for having
Yeah,
me.
absolutely. Have a wonderful, wonderful day.
You too.